Present me with your findings, please.
So, on examination, Mr. Fletcher had resting flexion of the interphalangeal joints on the fourth and fifth digits of the left hand. This was accompanied by wasting of the first dorsal interossei and also the hypothenar eminence on the same hand. When I examined the wrist, there was evidence of scarring present on the ulnar aspect of the wrist as well. When I examined power, there was weakness of finger abduction, and this was associated with hyperalgesia when I tested with sharp touch in the region of the ulnar nerve and altered sensation with soft touch.
What do you think the cause for this ulnar nerve lesion might be?
So when these symptoms are accompanied by a scarring over the ulnar aspect of the wrist, I feel that this is most likely due to an ulnar lesion, either due to trauma or due to a surgical procedure.
Okay. How can you be sure this isn't part of a more generalised neurological disorder, such as mononeuritis multiplex?
So in this case, I examined the patient's upper limbs. Ideally, I'd like to complete it by taking a full history and also examining the patient's cranial nerves and performing a neurological examination of the patient's lower limbs. In this setting, the reflexes were normal. In a generalised inflammatory neurological condition, I would expect some degree of areflexia.
Okay. Are you confident that we're not dealing with a C8, T1 nerve root lesion?
So when I tested the power in abductor pollicis brevis, the power was actually strong. And when I tested sensation in the T1 dermatome, that was normal. So I feel it's unlikely to be a C8, T1 lesion.
Okay. And are you also confident that the other major upper limb peripheral nerves are spared here?
So when I examined the motor aspect of the radial nerve, wrist extension was strong. This was accompanied by strong finger extension as well, demonstrating good motor function of the posterior interossei nerve. When I examined the abductor pollicis brevis, as said previously, that was strong, indicating good motor function of the median nerve as well. When testing sensation, I could only find altered sensation within the distribution of the ulnar nerve.
Fine. Let's say that the patient is now complaining of unpleasant, sharp shooting pains in that hand. Are there any treatments you could offer him?
So in that setting, we'd be looking at potentially a tricyclic agent, which is licensed for the treatment of neuropathic pain, such as amitriptyline.
Okay. Let's say we've given him some amitriptyline, but unfortunately he develops drowsiness and also complains of a dry mouth. These are common side effects of that drug. What else could you do for him?
So where the first-line therapy is ineffective or the side effects aren't tolerated, we could look at using an anti-epileptic drug, which is, again, licensed for the management of neuropathic pain, such as gabapentin or pregabalin.
Okay, but let's say, once again, unfortunately, sedation is caused by these drugs. How else could we manage it?
There's also an SNRI licensed as well, called duloxetine, or if tablets aren't being tolerated, then we can consider topical therapies such as capsaicin.
Do you think there are any investigations that are required here?
So I think it would be important to arrange neurophysiological testing. Nerve conduction studies in this setting would be useful, although the diagnosis is quite clear. It would help us to localise the lesion more thoroughly. Performing EMG could help to provide some prognosis as well in terms of recovery.
Okay, thank you very much.